Welcome to Conversations on Healthcare with Mark Masselli and Margaret Flinter. Our guest this week, former FDA Commissioner Dr. Scott Gottlieb on his new book, Uncontrolled Spread. Now, here's Mark Masselli and Margaret Flinter with their guest, Dr. Scott Gottlieb.
We're speaking today with Dr. Scott Gottlieb, physician and 23rd Commissioner of the U.S. Food and Drug Administration from 2017 to 2019. Dr. Gottlieb is a senior fellow at the American Enterprise Institute. He also serves on the board of Pfizer, which produced the first approved vaccine for COVID-19.
Dr. Gottlieb is the author of Uncontrolled Spread, Why COVID-19 Crushed Us and How We Can Defeat the Next Pandemic, which just debuted on the New York Times bestseller list. He's also a medical contributor to CNBC. Dr. Gottlieb, welcome to Conversations on Healthcare. In your book, Uncontrolled Spread, you note that America was failed by not only some bad political decisions, but also an ill-prepared public health infrastructure that you described as the fog of viral war. We know there were missteps along the pandemic's trajectory, and particularly you call out some at CDC, which I think we've all long considered the gold standard for public health. But you point to issues in the inherent culture at CDC that contributed to this, and that it just wasn't structurally designed for rapid response to a large-scale crisis. Share some of that analysis with us.
Yeah, look, thanks for having me here today. The CDC is the gold standard for public health. There's no question about that. But there is a difference between the CDC's sort of normal function and being able to respond to a public health crisis of this magnitude, having the logistical capacity and the ability to gather and do real-time analytical work to inform policy decisions that need to be made in the moment. CDC is sort of a deeply analytical organization, high science organization, accustomed to doing very exquisite scientific analyses to try to be the definitive word on a public health question, not the first word on a public health question. In the setting of a crisis like this, when you need to have a capacity to mount a very large coordinated logistical response, for example, being able to develop and deploy massive screening, massive testing that was required early on in the pandemic, or you need the ability to gather real-time data and do very rapid analysis to inform decisions like, what are the modes of transmission? What are the geographic and social compartments in society where the virus is spreading? How do we take steps to reduce transmission? Should we stand 3 feet apart or 6 feet apart or 10 feet apart? What's the right distancing? How effective a mask is going to be? Answering those critical questions, we really didn't have an organization capable of doing that in sort of the real-time fashion that was required for this crisis. CDC just didn't have the resources, the culture, the aptitude to do that. And it's not an argument for sort of building a new organization, building a new agency. I think what we need to do going forward and thinking about this is how do we build those capabilities into CDC? I think there was a sort of a presumption that CDC had this ball and they were able to discharge this mission. It just was never going to be the case. And policymakers were slow to realize that.
Dr. Gottlieb, your book, Uncontrolled Spread, congratulations. Debuted a week ago, and we're marking at the same time 700,000 American deaths from COVID-19, and we're still being crushed by this virus, but analysts are predicting the pandemic phase will end next year, shifting from a pandemic to an endemic. And there was some promising news this last week on a new oral therapeutic produced by Merck that reduces illness and hospitalizations by 50% in infected people. You're calling this a new development, a game changer. Tell us more about the drug and your thoughts on why America might not be able to take full advantage of the drug because we're simply not buying enough doses.
Yeah, look, this is a orally available drug from Merck. It's probably the most profound treatment effect that I've seen from a pill in the treatment of any respiratory pathogen. 50% reduction in the risk of hospitalization and death. And this was a population of patients that it was tested in who had risk factors for COVID. They had one or more risk factors for COVID. And they were also symptomatic at the time that the drug was administered. So they had to be within 5 days of the onset of symptoms. And so they had advanced disease. They had already progressed in the course of the illness, many of these patients. And so it was a high-risk population, yet you still saw a very profound treatment effect. The problem is that we're just not going to have enough of it. Merck said that they'll be able to make 10 million doses between now and the end of the year. But the U.S. has procured so far only 1.7 million doses, and they have an option on some additional doses, but not a lot. We don't know exactly how many, but we do know that some portion, and maybe some good portion of that 10 million has been pledged outside the U.S. So to give you sort of a basis of comparison, 1.7 million doses might have been enough to cover us for a month of the Delta wave. If this drug was sort of approved for the targeted population. If it's approved more broadly, then it wouldn't have even covered a month of the Delta wave, probably would have covered 3 weeks of the Delta wave. And to give you another basis of comparison, we've stockpiled somewhere between 50 to 80 million doses of flu medicines in preparation for a feared pandemic flu. So we procured 1.7 million doses of this coronavirus drug in the setting of a raging coronavirus pandemic, and we've stockpiled upwards of 80 million doses of a flu drug for a flu pandemic that we fear but hasn't arrived yet. And so there's sort of a mismatch between what we need in the setting of this pandemic and what we ultimately procured. There's probably things we could have done much earlier to ramp up manufacturing of this drug to have more available now, but it's too late at this point. There's not much you're going to be able to do in the near term. And it sort of underscores the lack of preparation. This is another point I get back to in the book, not having the reserve capacity to scale the production of some of the therapeutics and countermeasures that you're going to need in the setting of pandemic. We just don't have available capacity in this country that's ready to go, that's being kept as sort of a hot base of preparedness.
Well, Dr. Gottlieb, the subtitle for another book on this, might be what we would have done and when we would have done it if we'd only known and really thought things through. And you talk about in your book the CDC first attempt at a COVID test failing and having to go back to square one with what that cost in terms of time and lives. And we recently had Harvard's Dr. Michael Mina on the show. And he says if we'd simply focused on providing all Americans with simple at-home rapid tests, we could have gotten out in front of the pandemic much earlier. And instead, we focused on the more complex PCR tests. Is that your conclusion as well? That and we say this as an organization that put enormous effort into doing mass testing clinics with PCR. Should we really have been focused on the rapid tests right from the start? Would that have made an appreciable difference?
Well, we needed an all of the above approach right from the outset. And I talk a lot about the testing failures in the book and get into it in a lot of detail why we didn't have tests that we could deploy more widely. But at some point in January, someone needed to recognize that this could become a global pandemic and we needed to get testing ramped up, not just the diagnostic test kits that can run on the complex PCR machines that are inside labs, but also the point of care tests, because there's a long lead time to actually developing those tests. And so we didn't get started on that till much later. And that's why we didn't have those rapid point of care tests and at-home tests like the Binax Now or the Lucera test until much later in the course of this pandemic. So yeah, we didn't have a good strategy about how to scale and deploy testing in this country in the setting of a pandemic. If you go back and look at the pandemic plans that have been done, most of them had been focused on flu and the pandemic preparedness, the tabletop exercises that we did. And I was part of some of those when I was in the federal government.
Sure.
Never really envisioned diagnostic testing being an essential part of pandemic response, because if you're dealing with a flu, first of all, the incubation period for flu is short, about 3 days. And second of all, you're not contagious until you're symptomatic. So testing isn't as essential a component to trying to identify asymptomatic spread and asymptomatic carriers, because number one, asymptomatic people aren't going to go on to spread the virus in an appreciable amount. And two, by the time you become contagious, it's a short incubation period. So you haven't been in contact with as many people. So doing the testing and the tracing isn't as essential of a component of actually preventing the pandemic, the progression of the pandemic. And three, the installed base of flu tests that are available in every doctor's office would be sufficient, because if you had a pandemic with an influenza A or an influenza B, doctors in their offices have tests that could differentiate influenza A from influenza B. And if that's the prevailing strain, if the pandemic strain is influenza B and you can diagnose them with influenza B, they have the pandemic strain. So we never really planned for being able to develop and mass deploy novel diagnostic tests in a setting of a pandemic, because we always planned for flu. And in flu, the testing wouldn't be as essential, and we'd have an installed base of testing that we could use. So, that was part of the real challenge early on, is no one thought about this. No one thought of getting the diagnostic test kit makers in the game early enough. And we've never had enough testing. And even now, we still don't have enough of these at-home tests that could be highly effective at controlling the spread of the virus. And the ones that are available are expensive, and many people are priced out of it. We haven't adequately subsidized it for people who are priced out of this market.
We're speaking today with Dr. Scott Gottlieb, former FDA Commissioner and author of Uncontrolled Spread, Why COVID-19 Crushed Us and How We Can Defeat the Next Pandemic. Dr. Gottlieb, as you say so eloquently in the book, the pandemic has shown that we need to reimagine the role at CDC. And you suggest that we amp up the intelligence capacity of the agency more in line with what the NSA does. But that will require an act of Congress. President Biden's infrastructure bill allocated additional resources to improve the capacity of the CDC. But the question is, have they allocated enough? And how should that money be deployed, if approved, to make the CDC more responsive in a future crisis?
Yeah, well, the argument in the book is that we can't rely just on public health conventions to alert us to outbreaks in would-be hotspots. We've long relied on the international health regulations, which is a binding set of commitments that countries make in the context of the work they do under the World Health Assembly as part of the World Health Organization. And countries sort of voluntarily agree to surface information if they're host to an outbreak of a novel disease. That hasn't worked. I mean, we've seen time and time again, countries haven't fulfilled their obligations under the international health regulations, including the Chinese government haven't fulfilled their obligations, not just in the setting of SARS-CoV-2, but also in the setting of SARS-1. We strengthened the IHR after SARS-1 on the hopes that if we strengthened it, it would be more binding. And the Chinese government still flouted the commitments that they made under those regulations. They still haven't shared the source strains of the virus. And so my argument is we can't rely on just public health institutions and public health conventions alone. We're going to have to get our intelligence services more engaged in monitoring these threats. There's actually been legislation introduced to do just that by Representative Schiff. So it looks like we're moving in this direction of getting our national security tools more engaged in a global public health mission. As far as resources, there's a lot of resources right now being allocated, and there's more being contemplated. The Biden administration put out a sort of template for what they think a future pandemic preparedness proposal should look like, and it includes an enormous amount of money in it. So I think the money is going to be there. The question is how to program it, and also how to give very specific guidance to CDC in terms of how CDC needs to reform itself. In the past, Congress has written legislation directing CDC to do certain things, and the agency has simply ignored the legislation. I mean, the one that's most apparent I talk about in the book is Congress sort of obligated CDC to build out a new infrastructure for data collection in the country, and CDC never implemented it. The GAO did a report and came to the same conclusion that the CDC, the agency, just failed to act on the Congress's mandate. So Congress is going to have to come in and very specifically reprogram that organization to create these capacities. They did it with FDA. So when I was at FDA, Congress was very specific and granular in directing the FDA to reform itself in certain ways. I think ultimately had a very positive impact on the agency, driving change in the agency. And I think they're going to have to do it with CDC. The challenge is there's not that many people in Congress who really understand the CDC well. I mean, there was a group of Congress people, senators, Congress people who understood FDA well enough to write very specific legislation. CDC has been a little bit more of a black box, and that's why Congress has sort of allocated money to CDC, but left a lot of discretion to the agency how it implemented reforms. And I don't think we can afford that luxury anymore. I think we have to have sort of a put together a commission or some group that's going to write very specific legislation prescribing a very specific set of reforms to get the agency to have the capacity to deal with a crisis like this in the future.
Well, Dr. Gottlieb, thank you for that. And your early comments and your response about what we did and didn't know coming out of China back in the late fall, early winter. At the beginning of the pandemic, it's certainly a case of if only we'd known. And those are some very good thoughts. But here we are with vaccination as our best strategy to stop this relentless progression of infection and death. And we have made progress, but we still see resistance in different places around the country, certainly watching the rates per 100,000 people in the South and the Midwest. And then recently, just really tragic news coming out of Alaska. But you've looked at the issue of federal vaccination mandates, which the president is attempting in certain sectors, and said probably not the answer, probably further politicizes vaccine uptake. But it does seem like we're seeing some movement, maybe some positive impact from the mandates. Is that still your thought, or are you swayed by some of the recent news showing some progress where there are mandates?
Well, look, I think certain mandates make a lot of sense, and I've been very clear on this. I think mandating vaccination among healthcare workers makes a lot of sense. I think the federal government certainly within the scope of its authority to mandate vaccination among the federal workforce. It's a matter of readiness of the federal workforce, the Department of Defense. I think we should be prescribing greater mandates in the Medicare program using the star rating system. We could be requiring Medicare plans to have to vaccinate a certain high percentage of their populations for COVID as well. We haven't done that yet. I think we should, because that's a very vulnerable population. But I think that the issue of mandating vaccination among private businesses and small businesses versus trying to use incentives to drive that, I think we need to look at that carefully. What I haven't seen is the policymakers in the federal government step forward and say, this is what we need to achieve in terms of vaccination rates. And these are the different policies that are going to get us there. And this is how much incremental vaccination we think we're going to achieve with these different policies. So we can actually do a careful weighing from a public policy standpoint of what we need to achieve and what are the best ways to get there. Right now, it seems very open-ended. It seems to be the policy is get more people vaccinated. We don't really know what the upper bound is that is achievable, let alone, sufficient from a public health standpoint in terms of providing a proper wall of immunity. And then let's do everything and anything we can and not really understand which policies are going to achieve more vaccination versus which policies are going to be more divisive, create more acrimony, create more division around vaccination, not necessarily achieve a lot of vaccination. So it doesn't feel very deliberate to me. It doesn't feel like have a very clear sense of where we want to get and what are the tools for getting there. And that's where I think we need to be much more careful in terms of policymaking. We ought to understand what the goal is. We ought to understand what the different measures are that could get us there, and what the trade-offs from those different approaches are. There's been no discussion of that. So at the end of the day, what is the limiting principle here? I mean, there's obviously an end to what you can do to try to drive more vaccination. But if you don't prescribe sort of a goal and a different set of measures and how you think those different measures are going to achieve the outcome, there's not a clear limiting principle to what you are able to do or willing to do. And policy should be much more deliberate than it feels right now.
Yeah, and I think you say that data should drive some of that policy, and we've got to line up that data and make sure that the policymakers are aligned with it. You talked earlier about the FDA thinking that it really didn't need a review. Perhaps the CDC does, but I know there's been a lot of criticism of both the FDA and the CDC around pediatric, the 5 to 11-year-olds, and sort of the time it's taken for us to get the vaccine developed for young people. What's your sense about the upcoming review that Pfizer has put their information in front of the FDA and the CDC around young people? But the American Academy of Pediatrics has come out and criticized the length of delay here. What do you make of all of that, and what's your sense about the timing for the 5 to 11 and then certainly the younger ones after that?
Well, look, I don't think this has been significantly delayed. It's maybe a month past where we thought we might have been 3 or 4 months ago, because the agency, the FDA, asked for some additional data. They asked for the trials in the kids ages 5 to 11 to be a little bit longer, a little bit larger. But so we're not talking about a significant amount of time. Now, obviously, in the setting of a pandemic, any amount of time is significant. But I think if the trade-off of that is that you're going to have a bigger data set, a better data set on which to base a decision, try to give the public better information, the public health can be benefited in the end, because you're going to be able to allow people to have more confidence about using the vaccine and maybe get more uptake. So this is where, you have to engage in that careful balancing, and you have to be very sort of prescriptive about what you're doing and why and what you think the trade-offs are. And I think that the FDA has been careful in doing that balancing. I think the FDA is oftentimes more deliberate and transparent about, what it's doing, what it thinks the trade-offs are, what it thinks the public health benefits are. And it's kind of getting back to the last discussion about, what are we trying to achieve in terms of vaccination rates and what are the policies to get us there. I think we've been fairly deliberate about it here. The agency is going to be meeting on October 26th to discuss the Pfizer vaccine and the company I'm on the board of, and kids ages 5 to 11. Assuming that meeting has a positive outcome, and the agency authorizes the vaccine based on the data sets that's available, the CDC would be prepared to meet very soon after that, almost immediately after that, as they've been doing, and make a recommendation. So this vaccine, I think is on course to be available by Halloween or thereabouts if everything goes well. And ultimately, these two agencies feel that the Pfizer data package supports its safe use.
Just before we wrap up, tell me what your sense is on the horizon. You were very positive about the Merck drug, but what else do you see the public should be keeping its eyes on in terms of the development that's going on with antivirals or other improvements in the science that have happened because of the mRNA platform and the DNA platform as well? What do you see out there that animates your thinking?
Yeah, well, look, we have a much better toolbox now than we did when we started. Certainly, I mean, we have a safe and effective vaccines, multiple vaccines. We have point-of-care tests that can be used at home. FDA has undergone sort of a dramatic cultural shift in terms of making tests available in the home for the diagnosis of not just an infectious disease, but a reportable pathogen. I mean, 2 years ago, that would have been unheard of, the agency allowing those kinds of authorization. Now the agency has undergone really a shift in its thinking around this. We have orally available, the Merck drug, an orally available drug that looks very promising. There's 2 more in advanced development, one by Pfizer, which I'm on the board of, one by Roche. All 3 of those drugs could potentially be available by the end of this year, shortly thereafter. So we have a much different toolbox. I mean, if we go into the future with effective vaccines, higher vaccination rates, we're chipping away at getting people vaccinated. We're at almost 78% of adults over the age of 18 have now had at least 1 dose. Most will complete the series. So we're building that wall of immunity through vaccination and also, frankly, through infection. I mean, people are getting infected and they do have a durable immunity, especially after Delta infection. We're going to have orally available drugs that could treat people who have breakthrough infections, or the small number of people who unfortunately choose not to get vaccinated will have drugs available. The monoclonal antibody drugs are highly effective. Those are being formulated in subcutaneous delivery, so you can deliver it in the doctor's office just with a simple injection. And in the advent of these point of care and home diagnostic tests, it's going to make testing much more accessible. Eventually supply will catch up to demand. It's getting there, and hopefully the costs come down. This is a much better toolbox, and it will allow us to turn this into a more manageable pathogen as we sort of transition from the pandemic phase of this virus to a more endemic phase, where this just becomes a persistent menace that we're going to have to learn how to grapple with.
Well, that is a positive note to end on. And we've been speaking today with Dr. Scott Gottlieb, former FDA Commissioner and the author of Uncontrolled Spread, Why COVID-19 Crushed Us and How We Can Defeat the Next Pandemic. Learn more about his latest work and access his book by going to uncontrolledspread.com. Follow his policy work at the American Enterprise Institute, or follow him on Twitter at Scott Gottlieb, MD. Dr. Gottlieb, we want to thank you for your analysis on our pandemic response, for illuminating ways that we can strengthen the nation's public health infrastructure to better meet the next challenge, and for joining us today on Conversations on Healthcare.
Thanks a lot. Thanks for having me.
Thanks so much.
Thank you.